Well, hello, friends. Thank you. Well, thank you all for coming so early in the morning. But don't you like this setup at Mars? Yeah, it's very, and if you're a tenant, and you're always welcome to sign on tenancy, it's free. It's free. So, all good. So I'm delighted this morning to be able to say that we've been at this for almost 5 years, and we've actually managed to produce something very substantial, and thanks to CMAJ for partnering with us, but really to put words to paper with co-authors who are patients, to add to the literature, which is burgeoning literature on patient-oriented research, and really say, we're in Ontario, we're ready, we've done it, and we'll do more. So it's just been a fantastic experience for me and my team personally. And I really want to thank you, John Riley, who's been at this since day one. We couldn't have gotten the product out without your persistence and commitment. Thank you. So we've had the counsel and great advice of Michael McGillian, Ross Baker, Frank Gavin, and David Moore, guiding us through this process. It wasn't easy. Many of the articles had to be reconstituted to appeal to CMAJ's editorial group, but you stuck with us and we produced this. I hope you're pleased with the document. So this morning, we're doing the launch, but it's more symbolic. But what we're actually doing is launching into patient-partnered research. And we've done this with Patients Canada from the very beginning. And without Michael Decter's leadership and patience and commitment, I don't think we would have gotten off the ground. Thank you, Michael. And Steiny's taken over as chair from Michael. Steini, my old boss and friend. I think we're going to go places, Steini. I'm feeling comfortable. We've actually started to appeal to foundations, and they're all coming and saying, yes, we'll do it with you, which is a great place, because 5 years ago, I wouldn't have known what to say. You know, if I'd said patient-oriented research, they would say, what? So right now, they're familiar, and so we're going to do this, and we're going to go places. And Dr. Bell, what can I say about Bob Bell? Without him, there is no SPOR, there's no OSSU, because I got no support from the ministries, and Bob from the outside said, no, we've got to do this. So I don't know whether if you remember, Bob, you kept on saying, what are you doing? When are you going to get this done? So that kind of push and support meant a lot. So we've done it, at least insofar as getting the patient paradigm started. We had two important issues in our remit. One from CITRA, one was patient-oriented research, and the other a culture change. I believe we're on our way to achieving, thanks to Patrick and Anne in the ministry with great support, we've come to a point, and I think we can only go up from here. Thank you. So I'd like to ask Steini to please say a few words. Dean Steini.
So it's my pleasure as chair of the board of OSSU to welcome people here today. I'm only going to take a couple minutes of your time. The first is to lay out that, you know, as you watch new ideas kind of roll out, they seem to grow in popularity, the wave sort of kind of crests, and then usually it dissipates, and we start looking at whatever the next new idea is. And people say, well, that was a good idea, but it was hard to figure out what it really meant, it was hard to put into practice. But I think actually the wave is not really crested yet, which is a very positive thing. We've now got in our hands something we can hold that says, actually, this isn't just an idea, this is something that you can do. And I think what's very powerful when you look through the supplement, you look through the teams that OSSU has helped establish, you look at the whole granting process, and Vasanthi, as usual, will be very modest about her own role in all of this, but you look at the leadership she's provided. This isn't just a bunch of lone voices that have said, well, something that involves patients would be a good idea. This is actually teams of researchers and patients from across the province. And if you look at each one of the papers, there's a researcher and there's a patient. I think that's a very powerful combination. And so the wave is still building, which I think is very, very exciting and something that shows hopefully sustainability for the long run on this. The second thing is that this is reflective of what's happened at OSSU. And Vasanthi has paid tribute to Michael's role as really the founding chair and someone who has championed through Patients Canada and other vehicles patients the whole time, and Bob's role in nudging and stimulating and gently prodding. I've been one of those people he's gently prodded over my career, and it's always been a positive experience in the long run. So it really, really, really helps when people have leadership like this within our system and help move this along. But it is now, I think, really a sustainable enterprise in many ways, as Vasanthi said, and I'm grateful for both. The other thing is I live in a world where people publish papers and that's the currency. And we have different ways of counting that currency. How many times does it get cited? How many people read it? What's the journal it's in? I think here, though, with this collection of papers, it's particularly symbolically important that it's in CMAJ, that it's brought together in a special issue. And I'm grateful to CMAJ for working with us on this. But this is our national medical journal, and this has an importance that goes beyond just the collection of papers themselves. And I'm grateful for that as well, because I think it symbolizes a cultural change, not only in Ontario, but hopefully at the pan-Canadian level as well. And so with that, I'm really grateful to be here. I'm grateful that this is the first official thing I get to do as the board chair. Grateful for Vasanthi and John and the rest of the OSSU team's leadership. I'm grateful to the researchers and the patients who've collaborated now in a sustainable way for 5 years to really create something different. And I know there's been a lot of figuring it out as we've gone along, but that's critical and important. And I'm grateful for the folks who've been here before us. And so thanks. And thanks, Vasanthi, for giving me a chance to talk. Thank you.
Michael?
What's most remarkable to me is that if you thought about the situation 5 years ago and you said CMAJ will publish a whole special supplement dealing with patient-oriented research, and it will be high quality, and it will be well received, and it will have an impact, people would have said, look, put a little water in your wine. And that's a pretty big dream. But thanks to the people in this room and many others, that's exactly what's transpired. And it encourages me to think that if we can transform, probably the most difficult and challenging area for patients is to engage with researchers. I mean, it's easier to engage with providers, not always well accepted, but to go into the most scientific and rigorous and organized part of the system and say, you have something to learn by listening to the patient voice, really took some courage on the part of everyone, and especially on the part of the patients and the patient advisors, to not be put off. I've said often that the problem with patients is that they're not like knockout mice. They come with views, and they're not the same, and so it's a whole different challenge than doing work in the scientific way with mice could talk. Probably it would be more challenging on that side. So I'm delighted. I enjoyed every minute of being involved in this. And I too want to thank Vasanthi and her team, who showed what a small group of people could really do, well led and with passion. And they were always terrific to work with, and they always found a way to get things done. I also, it was my first chance to say something to and about Dr. Bell. I've had the privilege of working with Dr. Bell from the Cancer Quality Council through his time as deputy, and he used to come to our big meetings and he would say, you all work for me, and then he would challenge us to do some things. And I want to say to him, we're all going to be working for you for a lot longer than you think, because you convinced us that the work was important to do, and you showed a great deal of courage in leading the ministry. It's a job I know a little about when it was smaller and there were 50% fewer or 30% fewer people in this province. It is a very hard job, and I never saw you do anything but look for the next challenge, look for the next innovative approach. And so I don't get to thank you on behalf of the whole province, but I would like to, because you made a huge contribution and you left a very strong team in place. And OSSU is one of those things that I was surprised the first time you called us in, because I thought, big job, you got lots to do. And then you were keen and enthusiastic about everything we were doing. And it gave me a sense of how important, I thought it was important, but to have the person running the Ministry of Health think it was important had a big impact. And I think it caused a lot of people out in the field listening to you to think, we ought to roll up our sleeves and figure out how to make this happen. This isn't just an idea that will pass. This is going to be a permanent part of how we try and improve the health system. So thank you. And Steini, thank you for being there through this process and then stepping up when I felt it was time for me to go and do other things and taking on the leadership. So thank you.
Thank you, Vasanthi, for the opportunity to be here. Thank you, Michael and Steini, for those kind words. And I'm going to restrict my remarks to about the next 45 minutes, if I could have the first 42 slides. There are some things I want to reflect on, and that is, how do we come to be in this place? And, you've got to pay tribute to Alain Baudet, who started, along with Jean Rouleau, the concept of patient-oriented research. And when I was at University Health Network, a hospital down the road, we were engaged in some initial discussions about this, and it was fascinating to be in the room where patient-oriented research was discussed 7 years ago, prior to the steering committee developing, prior to support units being funded, prior to the CIHR. Really, following Alain's bold and courageous lead, not a popular thing to invest in patient-oriented research by any means, but Alain had a vision. Jean Rouleau had a vision. Many people across this country had a vision. I think it's fair to say nobody had the same vision of what patient-oriented research was, what it should be, and what it meant. And the lovely thing about being here, probably about 7 years later, is once you start crystallizing it in the literature, once it becomes part of the recognized body of work that we can refer to, that we can cite, that we can actually look to for understanding the impact potential that patient-oriented research has. You in this room have come an awfully long way. And Vasanthi, I really thank you for being the person who day to day stimulated this movement at a time of great uncertainty, went out and found matching funds, did the usual cobbling together that we all do, the magic economy of how research works in this country. You are masterful at making it happen, Vasanthi. And Michael, the authenticity and the rigor and the gravitas that you brought to patient-oriented research in its initial stage was so critically important to say this is important. And it's advancing orthopedic research. In this supplemental, there's an article about hip fractures, for goodness sake. What could be more patient-oriented than hip fractures? And there are lessons to be learned here. And probably the most important lesson that I got reading through this is the incredible change in research culture that's required to make patient-oriented research come about. And a couple of examples of that. I mean, research in Indigenous communities. We all recognize that the most important thing in undertaking research in Indigenous communities is to understand what the people who live in those communities experience in their daily contact with the healthcare system, with health challenges that they have, and recognize that probably their approaches, living in different communities, more rural and restricted communities, are going to be fundamentally different Their experiences with healthcare and health are different, and we must approach those in a different way. We must bring the rigor of our research methods, but we need to engage the communities in understanding what their view is, and that is eloquently spoken to in these stories. The other thing that I think is crucial for us to recognize is this is so important to the future of a sustainable healthcare system. Because if our healthcare system is going to be sustainable with an aging population, with a high prevalence of chronic disease, the anticipation that we need to keep people as healthy as possible in the community, then the crucial thing for us to do is to understand how care management by those patients, by those citizens, is going to happen. And understanding how self-care and self-management works means that you have to get inside the heads of patients to understand how they reflect on their disease challenges, how they reflect on opportunities for treatment, and crucially, how we interact with their desires to stay healthy as possible in the course of managing their chronic disease. And that is purely patient-oriented research. So pay tribute to the people here on the podium, pay tribute to people like Jean and Hélène who are not here, pay absolute tribute to my colleagues, former colleagues in the Ministry of Health, Patrick and Ann, delighted you're here. Thank you so much for your leadership, because these folks are master cobblers. Master cobblers, not of making shoes, but of cobbling together sources of funds to make great projects like this go. And also pay tribute to the person who practices patient-oriented research in her day-to-day role of being the most important healthcare leader in this country. The person who saves more money for Canadian taxpayers, provides better access to medications for Canadian patients, and that's Suzanne McGurn. And Suzanne recognizes that if we're going to make great decisions at the policy level about how we decide what drugs to fund, and crucially, how much we're going to pay for drugs that we are going to introduce to the system, we have to get in the heads of patients. We have to know what patients want. We have to know what citizens want. We have to know what taxpayers want. So maybe that's the next challenge, is taxpayer-oriented research. I'm not sure.
Why not?
It'll probably get funded. But crucially, to the researchers in the room, you've done something crucially important. You've codified, you've structured, you've described in an academically literate way what patient-oriented research really means. So thank you to all of you for the work you've done. Thank you.
Thank you. I'd like to now invite Joanna Henderson with her partner, Jacqueline. Hi.
So thank you very much for the opportunity to be here today. This is a huge accomplishment from where I sit as being someone who's worked hard over the last decade to ensure that the work we do is informed by the people affected by the work we do. And so that's youth and family members and service providers and academics and policymakers across Ontario, across Canada. I'm here to tell you about our Youth Can Impact project in brief. So this is years of work we're condensing to 7 minutes. So we'll see how we do here. We were funded by OSSU to conduct a pragmatic randomized control trial of a new model of service delivery for young people for mental health concerns and addiction concerns. So we know that many young people who could benefit from service don't actually engage with our specialist treatment systems. And this leads to poor outcome in the long term. So we proposed that one of the reasons we had this problem, a very significant problem, is because the work we had done both as researchers and as system planners and intervention designers hadn't been informed by the young people themselves who were intended to be served by these systems. And so with the Youth Can Impact project, we co-created with young people both a new model of service delivery and the research project itself. And Jackie's going to tell you more about it. I'm going to give you the basics. So the Youth Can Impact project is, like I said, a pragmatic randomized control trial where young people are recruited at entry point to 5 different hospitals across Toronto. Then they're randomly assigned to either continue on their treatment pathway, so our treatment is usual condition, or to receive services in the community through one of 3 integrated hubs that we created together with youth and families and our community partners. And those hubs are across Toronto. This model of service delivery was intended to address gaps that we saw in terms of access and wait times, and also to improve the overall quality of service. Most importantly, it was a real opportunity for us to test and build new practices in engaging young people. Our project involves, as I said, 5 hospitals, 6 or more community partners, youth and family members, and multiple sites doing multiple things. So as you can imagine, governance is really important. And when we took on working together with youth, we decided we're not going to do this in a small way. We're going to go all the way. We're going to co-design, we're going to partner, we're going to be co-decision makers. And so we set up a governance structure to govern both the development of the intervention and the research project. And that governance structure includes youth with lived experience of mental health concerns, substance use concerns, service access, inability to access service at all parts of our decision-making body. That helped us develop the project and develop the intervention. Jackie's going to tell you more about what does that actually mean. So how did our project differ as a result of engaging young people in our services?
So youth are engaged throughout the project at many different levels. As a youth engagement facilitator and staff at CMAJ, part of my role is to sit on all the Youth Can Impact meeting groups, bringing the youth voice and opinion to the table. I also coordinate the youth advisory group for the project, where I regularly meet with a group of over 10 young people with lived experience. During these meetings, I'm able to bring back discussions and issues from each of the groups that I sit on, and this allows for more youth to be involved in larger decisions that will impact the project. The youth team on the project has also been involved in key decisions. We supported the development of the values that the clinicians and researchers should uphold during the project. The youth advisory group also played a key role in determining the primary outcome measure for the study. We decided that we would be looking at daily functioning and not just symptom reduction. The primary outcome measure for the study is the Columbia Impairment Scale, which the youth and project scientists chose together. Our team has also made many different resources for the project, including a list of useful apps that young people can use to support their mental health journey. We also created a series of 10 postcards that describe the services that are available to the youth at the sites. Both of these resources have also been integrated into the Youth Can Impact service pathway. I will also do different types of training for staff at the Youth Can sites. I go into the community sites and speak with the frontline staff on how to use the apps list. I've also led training for research staff on different things that they should consider when working with youth in their role. Another project that we've recently been working on is the creation of a guidebook to support communities who are interested in developing a youth hub. Our team has worked with the youth engagement section of this guidebook. Youth advisory group members provided insight for and have reviewed several articles published by research staff at the McCain Center. 2 previous youth facilitators on our team were also authors on the protocol manuscript published for the ICCTs. I'm also a co-author on the article relating to youth engagement on the RCT, and 2 additional articles reviewing what youth friendliness can look like and mean in mental health and addiction setting, and a practical guide on how to engage youth in research.
So that's a summary of the kind of work we did. I appreciate Dr. Bell's comments about it really requires, and others' comments, it really requires us to work differently and requires a culture change in terms of how, both at the funder level and within our academic structures and on the ground, in terms of really thinking about what how we operate on a day-to-day basis. One of the things we did, or maybe you're going to talk about this. Yes, I'll let you go ahead and talk about this.
We've taken quite a few steps to support meaningful youth engagement with research. So we brought a resource here. If anybody wants one, we have them. And it kind of highlights some things like to-dos and don't with youth engagement and research. So some of the ones that I enjoy the most are valuing youth as partners on the project and supporting youth so they're able to participate in decision-making processes, making sure that youth have the opportunity to participate in meaningful activities on the project and avoiding tokenism. And through this work, we also recognize the importance of incorporating time on the project to support different types of engagement activities. Working with youth as partners requires more flexibility and providing time so we are actively able to contribute.
And I think if I can just say a couple of comments in closing. One, the value of engaging with young people, with their enthusiasm, with their different ways of thinking about things, new ways of thinking about things, has really brought a new energy to the research that we do and the research teams we've engaged with. And the other thing is that the OSSU funding of this particular project has really triggered our opportunities to build out this work across multiple different fund sources and multiple different contexts, including new funding from SSHRC to examine how to work effectively with researchers to promote youth engagement, as well as our Youth Wellness Hubs Ontario initiative, which really looks at how do we bring this hub model of service delivery through engaging with youth to diverse communities in the province of Ontario. So I would really like to take the opportunity to thank Vasanthi, Dr. Bell, Patrick and Anne, and all of the people who were behind, and of course the OSSU team who were behind really moving forward with this initiative in Ontario. So thank you.
Thank you, Joanna. Thank you. Jacqueline.
Good morning. I'm Nav Prasad, a family doctor and researcher at St. Michael's Hospital and the University of Toronto.
And I'm Diane Charter, a member of the Community Guidance Panel.
I should also mention I'm an associate editor for the CMAJ, although you wouldn't be able to tell that based on the large number of changes and corrections needed to our submission to this supplement. Thanks very much to our funders and supporters, CIHR SPOR, the Ontario SPOR Support Unit, the St. Michael's Foundation. Thank you, Vasanthi, Eddie, John, and Carolyn for the invitation to speak at this event, and thanks for organizing it early in the morning. I've been up for hours with two young kids who haven't adjusted to the time change yet, so it's nice to be out of the house. There are millions of people in Canada who don't take medications because they can't afford to. And over the last 40 years, there have been multiple reports by governments and researchers making an argument for publicly funding medications, but there hasn't been much progress in public policy. We wanted to do something a little bit different, and the first step was engaging people who are affected. Because around 60% of people have private insurance, the reality is most people are not passionate about this issue. So we donned T-shirts that said free medicines, and we canvassed the area around St. Michael's Hospital. One of the streets we walked down was George Street. And I don't know if you're familiar with that part of the city, but there's a fairly high volume of illicit drug selling down George Street. And we were stopped by a few people engaged in this trade, and they were wondering if we included in free medicines marijuana, and if we would be competitors or undercutting them by providing that for free. And we reassured, this was before marijuana had been legalized, and we reassured them that marijuana was not on our short list of essential medicines. We were successful in reaching people, and I think our community guidance panel does reflect the diversity of Toronto and Ontario as we had intended. That group met many times before the trial started, and they helped to design it. They helped to design the intervention. They helped to design the interval between the pharmacist dispensing medications and calling patients to check in on them. They helped design a script for the pharmacist to follow when he called patients. They helped design the outcomes. Instead of just asking about medication adherence and objectively measuring that, we also asked questions like whether or not receiving free medicines made it easier for patients to make ends meet at the end of the month. And they've also provided input on the knowledge translation. So through discussions with the community guidance panel, we've decided to make films, short films, that tell the stories of people, both in the control group, people who continue not to be able to access medicines that they need, including highly effective treatments for high blood pressure, diabetes, HIV/AIDS, life-saving treatments, and people who are now getting access to these medications. The Community Guidance Panel also wanted to learn more about the research process, so we had Dr. Andreas Lapakis come and meet with the group and discuss the anatomy of a clinical trial. Suzanne McGurn was kind enough to meet with the group and talk about how research findings can translate into improvements in public policy. For those of you here who haven't met with our panel yet, you're very welcome. You should do that. We meet on Thursday evenings at 5, and get in touch with me if you'd like to be involved. Diane's going to tell you a little bit more about the process.
Okay, just about the panel, I first found out about it. I was doing advocacy work for the LGBTQ community. And I saw these people walking along with brightly colored T-shirts offering free meds. And this is a community that really has some problems with prescriptions when they prioritize the necessities of life. Medications come very low on the list. So I was very interested in it, and I volunteered for the guidance panel. And was told that we were going to be very involved. Now, I'm old enough to be quite cynical, but the cynicism hasn't been based on fact at all. We've been very involved. I think one of the biggest advantages of the panel is the diversity in terms of the age and life experience. I've learned a tremendous amount from the co-panel members, and amazingly, we've just been involved in every step of the way, and this has been inspiring. It's been wonderful. I've really enjoyed it. We deal very closely with the research team members, and after we discuss a problem, we have open discussions with every meeting. After we discuss a problem, then suggest some actions, and when the team comes back at our next meeting, they report back on the actions that have been taken. So you know that you're being heard. I think probably the most important thing for the panel members is we know we're being listened to, we know we're being taken seriously, and we know, most of all, we're making a difference. And that makes it all worthwhile. Okay.
Great. Thank you. Thank you.
I'd like to acknowledge a few of our authors and co-authors who are with us this morning. Doug, thank you so much for your work in the cardiac sphere. Michael McGillian, who wrote the hip attack article. Catherine Birkin, hi. Elise, maybe. Sam, here you are. Nick Reed. Where's Nick? Ah. And Shamus Mohammed. Wonderful. So we'll now move on to Diane. Thank you so much for accepting our proposal to work with you and all the work you've done, Diane. Please.
Good morning. I'm Diane Kelsall. I'm a family physician, and I'm interim editor-in-chief of the CMAJ, and I am thrilled to be here this morning at the launch of this very special supplement. I think you've all seen sort of the paper version, but just to let you know that an email went out this morning to about 75,000 Canadian physicians, alerting them to this with all the with links to all the individual articles. So we've also launched with Kim, our media and partnerships person at CMAJ, a big social media campaign to support this. So we're excited to be able to get the message of all these research projects out to Canadians and obviously beyond. We're publishing a series of articles in CMAJ called Patient Voices. And they're sort of a different kind of article because they have a sketch, and a sketch was made by a physician at the University of Alabama called Dr. Alan Bloom. And they're patients he's had encounters with over the past many decades, actually, and he has sort of statements. And there was one that struck me when I was thinking about coming here this morning. And a patient had gone to see him, and she just had surgery. And she said, the surgeon said a funny thing to me after the surgery. I said, what did he say? He said, I enjoyed it. Now, for those of us who've worked with patients, yes, there are encounters we enjoy. I recall a colorectal surgeon friend of mine come to me and he said, it's not that I wanted the patient to have that medical condition, but I'm sure glad they came to me. So we do appreciate that. I would argue, I think most of us would feel pretty, that's, you know, the enjoyment of the physician or the surgeon is maybe not a patient-oriented outcome, which is why we need this kind of research. We want to make sure that what we do in our research actually has a positive effect on patients. One of the things that I appreciated so much about this supplement was the honesty in it. The researchers, as you know, each of the commentaries had members of the research team, including at least one patient rep. And I look at this as a bit of a how-to. It's what we did, you know, what worked, but also what didn't work. And I think that's the honesty that's in this. And I hope that, and that's tough for research groups to say, you know, this didn't work, and we wish we'd done this better. We wish we'd done this differently. And that's tough to do, especially when it's, you know, out there in perpetuity. So I really want to congratulate the teams that worked on this, that had the courage to put forward what they found that worked, what didn't, and to share those ideas. CMAJ's mission statement is, we want to champion knowledge that matters for the health of Canadians and for the rest of the world. And that's why we were very excited to partner in this, because this is knowledge that matters. Our vision statement is best evidence, best practice, and best health, and we hope that being part of this project will take your best evidence, move it into best practice, and result in best health. So thank you all very much.
Thank you. I'd just like to invite Dean Ferguson, but as Dean gets ready to make his comments, I'd like to thank my team, Carolyn, Eddie, John again, and Kim. Thank you so much for all the communication that you've done around this. Dean?
Thank you, Vasanthi. So it's a great pleasure to be here on the issue of the special issue delineating 17 stories of our researchers and patients in research, embedded within research projects. The stories represent a new cultural change of involving patients, not just in the original, in the projects themselves, but what they can contribute to research in general, with priority setting, with determining the outcomes for a trial, what's patient-centric, what's patient-oriented. And now we have 17 wonderful examples, from the newborns to the elderly, from the chronic disease to acute disease, from managing and treating diabetes in indigenous populations to treating, you know, acute heart failure in the emergency room. The breadth and depth of these stories is wonderful. We learn from how we, you know, not, as Diane was saying, it's not just the things that work, but it's the things that don't work. And now we've got a community across Ontario, researchers, academics, and patients, to learn and to move forward with best practices and get better and better at doing patient-oriented research. My sort of 3 take-home messages from the 17 articles were number 1, that patient-oriented research is of value. It can be done, and having patients involved makes a considerable difference. But also the networking that has occurred across the province and beyond. We now have representation in the major universities, major centers, all working together from a diverse research backgrounds, all in clinical and health services research, but all pulling in the same direction. and from that coming best practices in patient-oriented research. The other sort of Ontario ingenuity here is pushing the limits on research design and evaluation. We have examples of step wedge design, cluster trials, cluster crossover trials, and we're leading not only Canada but the world in those designs and the ethical frameworks and regulatory frameworks to go with those designs. So it's great to see that across the 17 studies. The value of this issue, again, it offers that blueprint. It offers not just what works, what doesn't work, and again, the value of involving patients. So the next steps, as great as this is, and as a sort of a marker or beacon along the way, is I can only imagine when these results start rolling out. We're going to change and define practice in Ontario and beyond. Because patients have been involved, we've had that perspective. It's not a unique perspective, it is the perspective in each of these studies. And so when the Clean Meds results come out and Doug's results come out, it's going to be practice changing and defining. And I think that's what these 17 research projects and articles represent, and it's going to be wonderful to see. A couple thank yous. You know, in terms of the issue, people worked tirelessly putting it together. So John and Ross and Michael, Frank and David, putting that issue together. We thank you very much for doing so. And a special thanks to the OSSU executive, Vasanthi, and Eddie and the crew for doing a wonderful job of getting us this far over 5 years, engaging that cultural change, and I'm excited for the next 5 years. Thank you.
Thank you very much. So this sort of concludes our semi-formal speech fine, but please do stay, enjoy yourself, network. Thanks for coming, and Rick, thank you very much for making it this morning. Rick's going to be our new co-chair in his role as scientific lead for SPOR. So I'm looking forward to working with you. Thank you.